Again, welcome to our webinar, Uncovering Your Roots, Decoding Genetic Testing. Again, my name is Courtney Castrieraci, and I serve as a Patient Education and Registry Administrator here at the Foundation. It's now my pleasure to introduce our speakers. Geneticist Dr. Theodore Drivas is a board certified in both internal medicine and clinical genetics and sees patients at the Hospital of the University of Pennsylvania, where he's an assistant professor of medicine. He also co-directs the UPenn HHT Center of Excellence with Dr. Scott Treatola in interventional radiology, and is the assistant director of the scientific outreach for the Penn Medicine and Biobank. As a clinical geneticist, Dr. Drivas' goal is to provide diagnostic workup and medical management for any patient with a genetic or inherited condition such as HHT, who primarily sees adult patients with any suspected genetic disorder and has a special interest and expertise in the management of patients with cellopathy conditions. In addition to his clinical work, Dr. Drivas directs a research lab at UPenn, and the overarching goal of his work is to understand the intersection of common and rare disease genetics to uncover the genetic architecture and molecular mechanisms of human disease. And our second speaker is Zahra Girnary, clinical assistant professor of UNC School of Medicine. Zahra graduated from UNC Chapel Hill in 2014 with dual degrees in biology and psychology with a minor in Spanish for medical professions. After graduation, she spent 2 additional years conducting research at UNC in the Berg Lab. Zahra completed her graduate coursework in genetic counseling at the University of South Carolina and graduated with her master's degree in 2018. Following graduation, she worked at the Fullerton Genetics Center in Asheville, North Carolina for roughly 2 years, seeing patients in a variety of clinical settings, including prenatal, pediatric, adult, metabolic, cardio, and neurogenetics. Since 2020, Zahra has held a faculty position as a clinical assistant professor at the UNC School of Medicine. She works as one of the 8 clinical genetic counselors with cancer and adult genetics groups. She also has a specialty clinic in benign hematology and hereditary hemorrhagic telangiectasia. Zahra serves as the group shadow and coordinator and works with fellow residents and medical students and genetic counseling graduate students. She also guides and serves as a mentor to students interested in the field of genetic counseling. They will now both present on genetics and HHT and the importance of getting genetic testing. At the end of the presentation, we'll hold a 30-minute moderated Q&A session. Let's begin our program. Let's now take a poll while Zahra and Dr. Drivas turn on their video and set up their slides.
Courtney, can I ask while we're completing this poll, how many attendees are there? I can't see the number on my side. I'm just curious.
Currently, we have 21 people watching with us right now.
Perfect.
And about 50% of those have had genetic testing and 50% have not. And you're good to get started whenever you're ready.
Perfect. All right, so I'll get started. And my name is, I go by Teddy, really. So Teddy Drivas. I'm a clinical geneticist, just like Courtney mentioned, at UPenn. Me and Zahra today are going to talk about the genetics of HHT and hopefully answer your questions. And also just kind of discuss some of the things that we think is interesting and fascinating about the genetics of this condition. Why we think that you should all care about genetics. It's clearly the best profession to go into. We're not biased at all. So neither of us have any conflicts of interest to disclose. And to start off, I'll just go over the outline of what we'll be talking about. So I'll start off with an HHT overview, talk a little bit about the history of HHT, and then get into the history of the genetics of HHT and some of the molecular genetics of HHT that can hopefully answer some questions for that some of you might have about why there's so many genes, how the genes do different things. From that, that's that part. And then after that, I'll turn it over to Zahra, who'll talk more about the role of the genetic counselor in the clinic, the role of genetic testing, and some of the logistics involved with getting genetic testing done. So between these two things, these 1, 2, 3 different subtopics, hopefully we'll, like I said, answer a bunch of these questions. But if any come up afterwards, we have that 30-minute window to discuss together as a group. So let's start with the overview of HHT, or Osler-Weber-Rendu syndrome. So I always start my lectures by talking about history. I was actually a classics major. I should have put that in my, I like that Zahra mentioned her Spanish minor and things like that. Like, I think that it's important to think a little bit outside of medicine. So I always like to know where we came from. So the diagnosis of HHT, really one of the first descriptions, was by Dr. Henry Rendu in 1896. And he was the first person to really recognize that this was a condition that was characterized by bleeding, but it was different from hemophilia. And he published a report of a 52-year-old gentleman who had these recurrent nosebleeds and telangiectasies, just like we know for HHT, on the mouth, on the lips, on the face. And he mentioned in his report that this patient's mother and brother also seemed to have frequent nosebleeds, but the genetic cause, the hereditary nature of this condition, hadn't really been established yet. A few years later, in 1901, the famous Canadian physician William Osler, who spent some time here at Penn, at Hopkins, he kind of made his way around the Northeast, was the first to really put the deciding. He was the first to say this is a condition that is hereditary and genetic. This is a quote from one of his works where he said, in the 3 cases here described in the paper that he put forward, 2 belonged to a family in which epistaxis or nosebleeds had occurred in 7 members. And he describes a lot of these different features that we all recognize today as part of HHT. And so he really made the case, like 7 members of a single family were affected. So this is clearly a hereditary condition. A little bit after that, we get to 1907, where Dr. Frederick Weber, who was famous for some of his descriptions of skin findings in patients, presented an additional case where he actually gives Dr. Osler credit for saying that, when I saw this patient, it wasn't until Dr. Osler mentioned that there are these other findings I should be looking for that I saw these skin findings on this patient as well. And this is coming together now as a relatively common genetic condition. And then in 1909 was the first time that it was referred to by the terminology that we use today, hereditary hemorrhagic telangiectasia. And that really describes what it is. It's hereditary, it's genetic, it's hemorrhagic, it leads to bleeding. And telangiectasia is a name for the malformation, the difference in the formation of blood vessels that we see, and that's the root cause of all of the symptoms that patients with HHT have. But a lot of people, maybe not a lot, but some people still refer to it by the names of these 3 physicians, Osler-Weber-Rendu syndrome. We, in general, in medicine, and particularly in genetics, there's a movement to move away from naming conditions after the doctors that name them, because that's not very patient-centered and doesn't help anyone. What does Osler-Weber-Rendu syndrome tell you? It tells you the name of 3 dead physicians, whereas hereditary hemorrhagic telangiectasia tells you, the patients, the other physicians, what it is this condition is, and describes it a little bit better. And so this is the preferred terminology that we use today. So now a few facts about HHT. Some of these might be new to you, some might be old hat. But it's a relatively common condition. About 1 in 5,000 people are affected. And so while that might not seem very common, when we talk about rare disease, genetic disease, this is a common rare disease, as I tell the patients that I see in clinic. Oftentimes in genetics clinic, we see conditions that are 1 in 80,000 or 1 in 100,000. And so HHT really affects a lot of people. With that, you can do the math and find out that, if it's 1 in 5,000 are affected, that means that about 70,000 people in the US are affected by HHT. But I will note this is almost certainly an underestimate, because as many of you may have experienced in your own families, not everyone is severely affected. And there are many families that we know are undiagnosed. And there are probably families that are very mildly affected who have the condition, but won't rise to the attention of going to a doctor because of their nosebleed. It's something that's just, it's a family feature, and they never think more about it. So this is almost certainly an underestimate. And to put this number in perspective, a disease that most people know about, a genetic disorder, cystic fibrosis, I feel like most people, if you were to ask someone, yeah, I know what CF is, I know cystic fibrosis, it's not that much more common than HHT. It's a 1 in 3,500 diagnosis. And this kind of goes to show you that, sometimes publicity and doing the good work that the folks at Cure HHT are doing to raise awareness for this condition is really necessary, because there's no reason that HHT should be so unknown to so many physicians out there, whereas cystic fibrosis is known to most. ALS, from the ALS Ice Bucket Challenge fame, is even more rare. 1 in 20,000 people are affected at a given time in the US. And I put this last one, spinal muscular atrophy, or SMA, up here. It's one that probably most people don't know about, and it's much rarer. It's 10 times less common than HHT, affecting 1 in 50,000 individuals. But even though this condition is so rare, there are multiple targeted therapies for this now that essentially cure this condition. And so again, showing the importance of it's not just how common these conditions are, it's how much people are aware of them and how much awareness the family and patient organizations raise that can actually bring new therapies to the market and better diagnostics. So I hope that we can get to the state that the SMA field is in for HHG, where we can have real cures for patients instead of just band-aids to fix things, kind of tide things over for a little bit. We know that HHG is characterized by certain stereotypical findings. So one of the most common ones, the most common, is nosebleeds or epistaxis, which is seen in about 90% or more of patients. And similarly, these telangiectasies, which are these small vascular malformations that we can see on the skin and the mucous membranes of the mouth and on the fingertips, affect about 90% of people. And then a little bit less common, but still affecting most people, is anemia or low blood counts. And then we have these visceral AVMs, these other arterial venous malformations that occur inside the body. So pulmonary AVMs, ones affecting the lung, are seen in about 30 to 50% of people, depending on their genetics and on their family. Liver AVMs affect about 40 to 70%, again, depending on the genetics underlying genetics. And then we can see brain AVMs or cerebral AVMs. They're less common in only about 10% of people, but obviously important to know about as well. The underlying reason that patients with HHG present with the symptoms that they do is because I keep on talking about this difference in the way blood vessels form. And in case this hasn't been explained to you before, I'll just briefly walk you through it. If we have a vein here in blue and an artery in red, if there is an injury or some message that the body sends to these blood vessels to say, hey, we need to grow more blood vessels in this area. It happens daily in all of our bodies. What happens for most people, and including for people with HHG most of the time, is that when there's a stimulus for new blood vessels to grow, the body forms a very, very fine meshwork of blood vessels that get down to this tiny level called the capillary level, which is just one cell thick. And this is a normal blood vessel that functions normally, is not a major bleeding risk. It's what we expect, what happens in most of our body most of the time. But in patients with HHG, sometimes when the same message comes in to, hey, build more blood vessels, the blood vessels are built in a different way. And they're built just like it's shown here, and they're larger, they kind of twist and turn more, they form this nest-like structure, which is really what we see. To go back to this picture of the brain AVM that I showed earlier, this is an angiogram of an AVM. What we expect to see are these very fine blood vessels, but in an AVM, we have this nest of malformed, differently formed blood vessels that are characterized by two features. One is they're friable, meaning they're easy to break, which much more easy to break than the capillaries in the normal condition above, which is obviously why patients with HHG have these bleeding risks, nose bleeding, but also bleeding elsewhere. And because these blood vessels are larger, they can allow things through that shouldn't be able to get through. And this is one of the reasons that patients with HHG are at an increased risk for strokes if not treated appropriately. So it's really this difference in pathophysiology that underlies all of the differences that patients with HHG have. The nosebleeds, the telangiectasies on the lips, and the AVMs are all due to this underlying difference in the way that the HHG patient's body processes these messages to grow new blood vessels. So to make the diagnosis in patients, we really have two ways, but the way that we normally rely on, and you've probably heard of these, are the Kurosawa criteria. This is a set of different features. We assign 1 point for each. So nosebleeds or epistaxis, you get a point. If we see telangiectasies on your exam, either on your lips or fingertips or in your mouth, that's an additional point. If you have an AVM, an arterial venous malformation in one of the organs that I talked about earlier, that's a point there. And of course, if you have family history, there's a point there. And if you have 3 or more points through any one of these 3, we say this is HHG. We diagnose you clinically. And we'll talk about the utility of doing clinical genetic testing in the setting of a positive clinical diagnosis like this. But if you have 3 or more criteria, regardless of what your genetic testing shows, you have HHG. If you have 2 criteria, we say it's possible, and sometimes we do confirmatory testing, either look for visceral AVMs, if maybe you have epistaxis and telangiectasies, but you've never had imaging for AVMs. If we find one by doing a CAT scan, we could say now you meet criteria and you have HHG. And if it's less than 2 criteria, if less than 2 points, only one of these features, we say it's very unlikely. We expect most people with HHG to have at least 2 of these criteria. Now, the other way we can arrive at the diagnosis is through genetic testing. If someone has had genetic testing with a positive result, with a known variant that is causative of HHG, really that seals the deal. We would like to see at least one feature, as we expect people with HHG to have at least 1 or 2 of these features, as mentioned above. But if you have positive genetic testing, then that plus 1 or 2 features is enough to make a diagnosis. One thing I do want to point out, though, and another reason why genetic testing can be important, is that we can't always use the Kurosawa criteria in children, because a lot of these different features develop over time in patients. So if we're trying to diagnose a child, a 2-year-old or a 3-year-old child with HHG so we can appropriately screen them, it's sometimes not reliable to do Kurosawa criteria diagnosis-based testing, or make their diagnosis based off the Kurosawa criteria. And that's when genetic testing really can be important. If we know there's a family history and we can find what the variant is, testing that child so we can be very clear about, yes, this child is at risk, or no, he or she is not, can really make a big difference for the management of that child and avoiding unnecessary procedures if we find that they're not effective. I keep pressing the wrong button. It beeps at me. All right, so now let's talk about why we're all here for genetics. So here's a great timeline that Zahra put together for me. I can't take any credit for this, of the discovery of different genes and the timeline at which they were discovered. So the first gene, endoglin, or ENG, was discovered in 1985. This is the first known HHT gene. Shortly thereafter, about 10 years after, in 1994, ACVRL1 was the next gene that was discovered as causative of HHT. A little bit after that, SMAD4 was discovered in 1998. And then more recently, we've had 3 more genes that were discovered. There we go. RASO1 in 2003, GDF2 in 2013, and EPHB4 in 2017. So the genetic landscape of HHT is growing. But what's important to point out is that more than 95% of patients with classic HHT will have a variant, a genetic variant in one of these 2 genes, ENG or ACVRL1. So if we look at this in a table form, about 52% of patients will have an ACVRL1 genetic variant. This is of patients who have HHT. A slightly smaller number, and these numbers change depending on the publication you look at and the population you're looking in. About 44% will have an ENG variant, about 1% will have a SMAD4 variant, and then the other genes contribute less than 1%. And it's also notable, and we'll talk about this in a second, that some of the clinical features we see in these other patients are a little bit different than the classic HHT that we typically think about as the presentation for HHT. And it's also important to realize that about 2% of people who clearly have HHT, family history, personal history, about 2% have negative genetic testing. Either there are more genes to be discovered, which is possible, or our genetic testing is just not perfect. And we know that's the case. We can't always find the genetic variant in ACVRL1 just because we know there are limitations to the way that we do testing. It's getting better every day, but it's something to keep in mind that, just because you have negative genetic testing doesn't mean you don't have HHT. Most people will have positive testing, but keep that in mind. And the last point that I want to make is that for most patients, when we find a genetic variant, we find out that they inherited it from one of their parents. So if you're an HHT patient, and this is probably the case for most of you in the audience here, most people with HHT have affected family members and affected parents. But about 3% of people have what we call de novo genetic variants, meaning that they were the first one in their family to have this genetic variant and the first one to have HHT. All genetic variants have to start somewhere. They start in somebody. We all have genetic changes that we don't inherit from our parents. These are what we call sometimes mutations that they occurred in us as an embryo while we were growing. So about 3% of the time when we make a diagnosis of HHT, that person will be the first person in their family lineage to have the condition. But most of the time they're inherited, which is why we see such large families and so many people affected typically. All right, so why are there so many genes? And why is it so confusing? Why can't there just be one HHT gene? Well, the reason there's so many genes is that these genes function in similar pathways. So the first gene the ACVRL1 is a receptor on the cell surface, which recognizes that external stimulus from the outside of the cell that says grow new blood vessels. But it does that by binding to GDF2, another one of these factors on the outside of the cell. And this whole message is kind of stabilized by endoglin, the ENG gene. So these 3 genes all interact with each other, and they form the underlying signaling complex that allows the cells to grow and respond to the stimulus to grow more blood vessels. And once this stimulation happens, this signals through a complex that includes the gene SMAD4, another one of our HHT friends, that tells the cell to start turning on different genes to grow blood vessels the way that we expect. So you can start to see why there's so many different ways you can get HHT. There's different ways that this pathway can be deranged or broken. At the same time, EPHB4, another one of these HHT-like genes, is another cell surface receptor that interacts with RASA1, our last HHT gene that we know about, which also signals to do the same type of gene transcription. And importantly, these pathways talk to each other. So it's a big family of genes that kind of do overlapping functions. But what you'll notice is that they do kind of have their own little spin on things. So the genes in this box, the ones on ENG, ACVRL1, and as far as we know, GDF2, all seem to cause classic HHT, the classic features that we just talked about. Whereas SMAD4 is a little bit different. We know that SMAD4 has features of classic HHT with the addition of gastrointestinal polyps, Whereas the genes on this side, they're a little bit further removed. They cause an HHT-like syndrome that is more characterized by capillary malformations, and it presents differently than the classic HHT does. So although there are many genes, you can kind of see based on the way that they interact with each other, they kind of do different things and present differently in different people. And the last thing that I want to talk about is, before I turn it over to Zahra, is what do we learn anything by learning what gene an HHT patient has that is affected in them? And we do. There are certain trends. Now, these are not universally true, but we know that patients with ACVRL1 variants tend to be at higher risk compared to other HHT patients for lung and brain AVMs, whereas patients with E and G variants tend to be at higher risk for liver AVMs. GDF2 we don't have that much data on it. It seems to be somewhere in between for ACVRL1 and E and G, but we're learning more about it. And SMAD4, as I mentioned, the biggest thing that differentiates SMAD4 from the other genes is this risk for GI bleeding and for intestinal polyps, which can be problematic for sure. And so we definitely would want to know if someone had a SMAD4 related HHT. And then again, the last two variants here, genes here, EPHB4 and RASO1, are both these capillary malformation AVM syndromes. And just to show you what the difference is, these are telangiectasies in the top, classic, a pretty severe case, but classic HHT telangiectasies. Whereas this image below shows a capillary malformation on the skin of a patient with one of these. I think it's a RASO1 patient, in fact. So they just look a little bit different. The pathways are a little bit different, and they can present slightly differently. So I will stop there. I think I've already gone way over the time I said I was supposed to take. And I will hand it over to Zahra, who I think will be swapping sharing screens. So I'm going to stop sharing my screen and allow Zahra to share hers.
All right, so I'm going to share my screen. And you guys can let me know. Are you able to see my slides?
I can see them, Zahra.
Perfect. Awesome. All right. Well, I'm going to try to speed my way through this so that we can leave plenty of time for questions. But I am one of the genetic counselors. I am the HHT genetic counselor at UNC. My name is Zahra Girnary, and I'm going to talk about genetic counseling. So I work with a group, and I have a role within the clinic, and I try to be, I'm usually one of the first person that will see the patient when they walk in the room. So I am going to give myself a quick introduction of who I am, how our clinic works, and then my role within it. One of the biggest things that I do is I get a medical history from the patient, just a brief one, so that I can use it to determine if genetic testing is going to be helpful. I get a family history, and I also talk about genetic testing. So this is actually a family history of, this is called a pedigree of one of the patients that I saw. I had a 70-year-old male who had nosebleeds and he had telangiectasias. He also had a family history of nosebleeds. He had a brother with nosebleeds, a couple children with nosebleeds, and then his dad also had nosebleeds and telangiectasias. So genetic testing is most helpful in people who have possible HHT. So like Dr. Drivas mentioned earlier, if you have two features or two of those criteria in the Curacao criteria, you're possible HHT. It's also helpful if you have at-risk family members, so siblings, children, or if you are too young to show symptoms and we don't know if you have HHT or you don't. So in this patient, he met 2 out of 4 clinical criteria. So he was possible HHT, and so we discussed genetic testing. And so the logistics of genetic testing, I've laid them out here, but basically we do it through blood. It can also be done through saliva or cheek swab. That blood is then sent out to a laboratory, and most of the labs that we use do benefit investigations, where when they get your sample, they will also get a copy of your insurance card, and they will let us know, or they will let you know what is the estimated out-of-pocket cost. Once that is done, about 3 to 4 weeks after the blood is drawn, we'll get a result, and I will review those results, and then I will call the patient with those results. I'll write a summary letter, and then I also will encourage the patient to share that result with their family. A big part of what I do is talk about the types of results we can get. So one of the types of results we can get is called a pathogenic or a likely pathogenic variant or a mutation, also called a positive result. So that means we found an answer. We know you have HHT and we know why you have HHT. Once we know why you have HHT, we can use that information to test family members. Like Dr. Drivas said earlier, genetic testing is good, but it's not perfect. And so we are usually about 95% of the time when someone we're like, yep, you've got HHT, you've got the clinical criteria, we're able to find a genetic testing, or we're able to find the answer. But sometimes we can get a negative result. And so that will be a benign, or it means that we didn't find anything. We don't know if you've got HHT. And usually what happens is that if someone's got possible HHT, they still have some of the features. What we'll do is we'll see them back. We'll just double check and make sure, do we think that this is HHT? Do we think that this is something else? And then a tricky result that we can get is a variant of uncertain significance. So that means that we found a genetic change that we cannot say it causes HHT, and we cannot say that it doesn't. I like to think of it as like a seesaw. So if you have positive one way and negative the other way, you'll have uncertain in that middle. And a lot of the times uncertain results might be leaning one way or the other, but until that seesaw can hit the floor, we can't say it's positive or negative. And so that's part of my job, that's part of Dr. Drivas's job, is to figure out, is this suspicious? Is this a suspicious genetic change, or is it not? So if you have a benign, or if you have an uncertain result or a negative result, doesn't necessarily mean you don't have HHT, but it might make it less likely, and it just means we need to look at you and do further evaluation. So there's a lot of factors to consider when you do genetic testing, and there are a lot of things that patients will ask me about, and I put some of them here. So one of the things is guilt. Like, oh my gosh, I had no idea I even have this until my child was diagnosed, or what if I pass it on? I don't even know I have it. So those are oftentimes concerns that people have. And we oftentimes also have people that are like, well, why did all of my siblings are affected? How, like, I feel bad, I didn't get it. And so, there's nothing you could have done to cause it. There's nothing you could have done to prevent it. HHT just happened. And we do, though, have options for prenatal testing. If someone is found to have HHT and they do want to make sure that maybe they don't pass it on to their children, we do have options for that. Another thing is cost. So cost is a huge, huge thing. So genetic testing is very affordable nowadays. We work with laboratories who do all that they can to make it so that cost is not a barrier. Some of the things that they have is that, first of all, most insurance companies will cover HHT testing. Two, if people don't have insurance, or if it costs too much to go through insurance, they do have self-pay prices, and that average is around $250. And so it's not nothing, but it's not in the thousands of dollars. And so it's much more feasible. There's payment plans that are available. We also have financial assistance options. So there's a lot of things that are available, so that cost is not a barrier. We don't try to make cost a barrier for genetic testing. And so genetic counselors can really help with that. Another thing is genetic discrimination. So sometimes we're like, well, I've heard about life insurance, I won't be able to get life insurance, or my kids won't be able to get life insurance, or health insurance, or just any kind of discrimination. So there is a federal law called the Genetic Information Non-Discrimination Act, or GINA. GINA protects you from losing your job or your health insurance based on the results of your genetic testing. You cannot lose your job just because you have HHT. You cannot lose your health insurance just because you have HHT. But GINA does not apply to life insurance or long-term care insurance or any of your opt-in insurance plans. And yes, children aren't going to have those. You're not going to get life insurance for a 5-year-old. You're not going to get life insurance for a 15-year-old. But the caveat is that life insurance companies can use all sorts of information to not give you life insurance. So they might say, oh, well, you had a mom with HHT, so we're not going to cover you. Or, oh, there's diabetes in the family, or whatever the case might be. So it's not just HHT, but it's definitely something to consider and something that can be discussed further. I put a resource over here, ginahelp.org, which can walk patients through just the protections that GINA does and does not provide. And then the last thing is family. So can't tell you the amount of people that I've sat in that chair and said, this isn't going to change anything for me. I'm just here for my kids. And that's not uncommon. And that's actually great. So genetic testing is helpful in the person who has HHT. I don't want to test a child if they have nothing, because I don't know what I'm going to look for, if I don't know what a negative result is going to mean. So I want to test the person who has HHT to make sure that if something is there, and if we can find it, that's the person I'm going to find it in. So a lot of labs actually will offer no charge family variant testing. So some of the labs we use, if an answer is found, they'll say, you know what, we won't charge any of the family members to get tested if they do it in the next 3 months or if they do it in the next 5 months. Now, there will be a cost. There may be a cost associated with the actual genetic counseling visit or the clinic visit, but the testing itself will be no charge. And any geneticist or genetic counselor that you take a report to will know exactly what to do with it. So the most important thing is if you have genetic testing done, send that lab report to any family member. You can de-identify it if you need to, if you don't want to be linked to it, but send it to the family member because we will know exactly what to do with it. And it's just a universal language that we all speak. Genetics is a universal language. All right, so let's go back to my patient. We did genetic testing on him and he did test positive for a pathogenic variant in ACVRL1, ALK1, and he has 3 children. So if someone has HHT, there is a 50% chance that they will pass on HHT to their child. It's 50-50 every single time. It's a flip of a coin with every child you have. So if you have 4 children, doesn't mean 2 of them will have it, 2 of them won't. It could be 3 and 1. It could be 2 and 2. It could be nobody or all. So 2 of his sons, one of his sons actually lived in the area. They lived in Chapel Hill and the other son lived in New York. And his wife called me up and she said, you know what? He's coming down from New York. Can you see them? Can you test them both? Yes, we can. And so I helped them get family variant testing. We were within the time frame. And one of them tested positive, one of them tested negative. The daughter has yet to get genetic testing, but it was nice. We kind of expected that one of the son with nosebleeds to test positive, and he did. And he also has a son that has nosebleeds. So we do recommend confirmation of a diagnosis for her. So I wanted to spend the last part talking about common misconceptions. Some of these actually came from, I think, the Facebook groups or just things that are out there. So I'll spend the last few minutes doing that before we open it up to questions. So 1, does everyone with a clinical diagnosis of HHT need genetic testing? I bolded clinical diagnosis of HHT because that means you have 3 out of those 4 criteria. We know you've got HHT. Do you still need genetic testing? It depends. The answer is not clear cut. So 1, is the familial mutation known? Has anyone in the family already had genetic testing? If the answer is yes, and if we have that report, then no, you don't need genetic testing. So it might be, oh, my sister had genetic testing and my daughter is worried about her risk. So you're the middleman. I might be the middleman if my sister had testing and my daughter is worried. But if my sister had genetic testing and I have that report, I can just test her. I can just test the daughter using the ANS report, no big deal. Because if you already have a clinical diagnosis, I'm pretty sure you have the same genetic change. I don't need to test you. But if you don't have symptoms, then I totally would want to test you. If we're not sure if you have HHT, then yes, we want to do the testing. And if genetic testing has not been done, or if you're unsure, and it could be, oh, like way long time ago, my family was in a research study, we might have had it. So if there's any kind of uncertainty, then yes, let's do testing. Or if you had genetic testing a long time ago and tested negative, let's just say for 1 or 2 genes, we can do updated genetic testing. So yes, then we would want to do it. Another thing is HHT gene mutations can skip generations. That is false. If there's a familial variant in the family and someone tests negative, then you cannot pass on what you do not have. Genes do not skip generations. Sometimes it looks like it could skip generation because it might be, oh, my mom never had nosebleeds or maybe had 1 or 2 nosebleeds. My grandma bled all the time. So it can look like it might skip just because of how HHT can look in different people. And that's because of variable expressivity, which means that 2 people with the exact same genetic change can have different severities. Some people can have more telangiectasia, some people might not. Some people might have more severe nosebleeds, some people might not, but it's the exact same genetic change that is causing it. Children don't need genetic testing for HHT. My baby doesn't have to be tested. They're not ever going to bleed. Yes, they're not going to have nosebleeds, but we do want to do testing on children. So yes, we would. It is false. Children do need genetic testing for HHT. That is because there is a chance for brain AVMs. There's a small percentage, about 10% of people with HHT will have brain AVMs. But if they're there, we want to know that they're there. And we want to check for that at birth. But we don't want to and the way we check for that is doing brain MRI We don't want to do a brain MRI on a baby who doesn't need one. So if we know that they have HHT, then we'll say, all right, well, we know we need to do the brain MRI. If we know that they don't have HHT, then they don't need it. And I put over here that there's a transcranial Doppler that you can do. So it's kind of like an ultrasound, which can look for big brain AVMs. So sometimes you may not know at birth. I don't know if the child has HHT. We haven't gotten testing. That's okay. We can do a transcranial Doppler if that's normal. Then we can usually do a brain MRI at 2 or 3. We have a little bit more time to do that testing. But genetic counselors, like I've coordinated genetic testing on cord blood. So we want to make sure that we can know if a baby has it or not. And if they don't have a normal brain MRI, then we'll see them back when they're in for their other screening in adolescence. The other one is, I don't have nosebleeds, so I don't have HHT. That is also false. Only 90 to 95% of patients with HHT will have nosebleeds. And that number is to age 45. So you could be in your 20s and never have nosebleed. And then maybe develop them in your 30s, maybe develop them in your 40s. We've had patients that never had a nosebleed until they were in their 60s. So anybody at risk for HHT should get genetic testing. So just the last slide is we can do a lot. Genetic counselors are do a lot of things on the back end. We help coordinate the testing. We can fight with insurance companies for coverage. We can help you figure out where you can get HHT testing near you. We can help you figure out how do you talk about this with your family members. Just a lot more. So feel free to reach out to your local counselor. And the last thing is, if people are interested in genetic testing, the first thing I'll do is I'll recommend that they visit the Cure HHT site and find a center near them. If there's no center near you, then contact your genetic counselor or anyone near you, and we will help you find a genetic counselor. We'll help you find a place to get testing. So this is our information for Dr. Drivas and I, and this will be also, because this is recorded, it'll be online. I'm going to go ahead and skip to the end for some of the questions that Dr. Drivas and I can both address. Thank you.
Thank you both for that wonderful presentation. These were questions that were submitted by some of you guys. Maybe not all of you guys might be on here tonight, but if you watch the recording back, then you can get your questions answered. So the first one is, if our family was tested in 1998, should we be retested? I was the only positive one, but is it possible that someone else had a false negative?
Zahra, how do you want to divide these up? How would you like to?
I don't mind. I can do this one. You can do the gene therapy.
Sure.
So the way that genetic testing works, if someone was tested in 1998 and a positive result was identified, it is not likely that there was a false negative. So if we know exactly what we're looking for, we just fish for that. We say, do you have it or do you not? And the nice thing is that because we know we're looking exactly for that, we're gonna find it. Also, genetic testing is much better now than 1998. So for sure we'll be able to find it today. But no, it's unlikely that someone had a false negative. So if someone had a negative result, then that's a reassuring result because the variant is known, the mutation is known.
Yeah. The flip side of that, I'll add, which you already mentioned, Zahra, was that if the entire family had negative testing in 1998, we have learned a lot more. So it might, if no one has tested positive and there's a clinical diagnosis of HHT, we will often repeat testing now that we know about more genes and that the methodologies have gotten better.
Yep, exactly. It's just updated testing. See if you find anything now.
Yeah, great. And the next question is, has gene therapy been used in HHT patients? Is gene therapy on the horizon? Is it safe? What's the new research?
Perfect. So I will try to answer this. This is a whole topic that we could discuss about treatments for HHT and gene therapy in particular. There is definitely a lot of excitement about gene therapy kind of across the board, across conditions right now, because we have started to use it in patients and it's been effective. I'll brag for a minute to say that the first in vivo gene therapy, meaning like one that was used in a patient and in a human patient, and the first one that was approved by the FDA actually came here out of Penn after one of my the lab of one of my former mentors, Dr. Gene Bennett, and that was about a decade ago now. So we proved that it can work. Now, the problem with gene therapy and why it's not always applicable to every condition is that you have to understand what are you trying to fix and how many cells you have to target. So for the condition that Jean Bennett treated, which was inherited blindness, you have to treat the retina. And the retina you can get to with an injection into the eye. It sounds gross, but you can do it, and you can make sure you target every cell with gene therapy, or as many as possible. With HHT, we have to target basically all the cells that line the blood vessels, essentially throughout the body, to try to prevent these telangiectasies and AVMs from forming. That's a higher bar that we have to hit. So I think that the jury still are out on how effective gene therapy would be, but is it safe? Is it effective? It's been proven safe and effective in these other conditions. So the question will just be, how can we get it to be effective in HHT, where we have to treat more cells throughout the entire body? So that's my bird's eye view. But what I will say is that there's a lot of excitement in HHT in treatment using small molecules like just drugs, medications that we take. And there are many ongoing clinical trials that Cure HHT is part of in helping sponsor and getting off the ground and getting the word out for. If we could just advance the slide for 1 second, because I have one slide I wanted to put in here. I think that's Zahra maybe who's in control.
Oh, yes, there we go.
So there is a website, if you haven't heard of it, called clinicaltrials.gov, where any clinical trial that is ongoing in the United States of any kind has to be registered on here. And you can search by term. So this is just a screenshot I took of where I searched for HHT, or for I think I actually said HHT instead of the full. You can see there it also included hereditary hemorrhagic teloid. Like, it's smart enough to know that I was looking for other things. It threw in a few other things that are not as important. But with this search term, there are 120 trials that have been registered. Now, not all of them are ongoing. Some have completed, as you can see here. But there are many trials looking at different molecules, small molecule medications that will hopefully prevent bleeding and prevent AVMs from forming in the first place. So these are easier to get to market. I think that the timeline will be more amenable to, like, you want an answer soon. You don't want one 15 years from now, right? Gene therapy is more like a 10 to 15 year kind of development pipeline, whereas these could be approved within the next 3-4 years. So every once in a while, check clinicaltrials.gov if you're interested, see what's available. There's no harm in reaching out. If it's not like if you email them to ask about a trial that they force you to enroll. You can ask what's going on, what's this trial about, and you can get information about it. And if you're interested, you can potentially enroll in a trial, and you can always withdraw at any time. So there's things to think about. And I'll stop talking. I'll let Zahra go back to the slide before. Next question.
No.
I talk a lot. Can you tell?
I am also a chatty Cathy. Okay, so that's the next one. What are de novo mutations and are they common? So Dr. Drivas talked about this in his slides. About 3% of patients with HHT are found to have a de novo mutation. So no, they're not very common, but they do occur. A de novo mutation, de novo means of new. So that is a new genetic change that is happening for the first time in the family. It was not inherited from a parent. So it was not, but it is in the affected individual. And since they have it, it can now be passed on to children. So even though it wasn't inherited from someone, it can be inherited by all future offspring that person will have. So that's a de novo mutation. That means it's a new thing that happened just by chance. Again, nothing you did to cause it, nothing you could have done to prevent it. Yeah. Just luck.
All right, I think, and I can read the last one. I'd be curious. I feel like we might have different opinions or like different ways of thinking about this one, Zahra. So maybe we can both answer this one. So as a parent with HHT whose child does not, at least as of yet, have HHT symptoms or diagnosis, what are the pros and cons to getting this patient or his or her other family members and their child tested? So Zahra mentioned some of these pros and cons, I would say already, in terms of why we would want to know for a child if they have HHT, even if they don't have apparent symptoms. So there are the pros of being able to diagnose a child definitively with genetic testing. If we find a variant in mom or dad and we can test the child and say, yes, they definitely have it. Yes, they definitely need that brain MRI. But if they don't have it, we can spare them the MRI. We can spare them sedation. If they're a young kid, they often need to have some kind of anesthesia in order to let them stay still enough to have the MRI. We don't want to do that if we don't need to. So there are definitely pros and cons to screening genetically first, which will cost them at most some blood and a little bit of money. Hopefully it will be covered by insurance, and as little, depending on how you do the testing, sometimes just saliva. A lot safer and easier to do that than it is to sedate a child for a brain MRI that might not be necessary. So those are some of the pros, I would say, of getting people tested. Now, the cons, in my opinion, Zahra also mentioned. One is cost, although cost has come down substantially. So I would say, and there are ways we can hopefully get around costs if it does seem like insurance won't cover testing. The other one that I think, and I'd be curious, this is where I definitely want to hear Zahra's take on this as well. If you have a perfectly healthy child who, let's say that they're 12 years old, they have no medical history whatsoever, but they're a 50% chance of having inherited HHG from their parent. The thing that I would just mention, again, would be this GINA law and the limitations, being that it is possible that getting life insurance on a 12-year-old who is completely healthy without a genetic diagnosis of HHT, life insurance, I'm not sure if it said health insurance, getting life insurance or disability insurance, one of the unprotected by GINA insurances, would probably be easier. And so if you're thinking about testing someone and the child is completely symptom-free, it's not illegal to say, or it's not insurance fraud to say, I'm going to wait on testing until I secure my child's, get a life insurance policy or something like that. So that is something we sometimes discuss when we're testing somebody who is truly asymptomatic, a child or another relative, a brother of somebody, for instance, who's affected. We sometimes really push that a little bit more as being like, we should probably pay a little bit more attention because we are potentially taking your medical record from blemish-free to having something on it that might be used against you when you're getting insurance. So that's the biggest con that I could think of, but it's something you can plan for. I'm curious what you have to say, Zahra.
Yeah, no, it's definitely something that we discuss. The thing that we've run into is that a lot of times there will be discrimination due to just the family history of HHT. So yes, you have a healthy child, but even in families that don't have HHT, they might say, oh, well, your mom had ovarian cancer, so we're not going to cover you, or whatever it might be. And that's what's been harder and harder and harder, is that there are definitely life insurance policies that don't ask about family history, and they don't ask about, all the ins and outs that could prevent them from coverage, but sometimes they're more expensive. Sometimes it has to be multiple policies. The thing is that you can definitely get life insurance for a child, but it does have to be, a parent has to get a policy on their child. They cannot get an independent policy until they're 18. And that's also hard. So I can never call myself a GINA expert because I'm not, and I'm not a lawyer and I'm not a legal expert. So whenever I have someone who is very, very concerned about life insurance and long-term care insurance and any of that, I do recommend that they talk to a lawyer. The thing is that you don't have to have a molecular diagnosis to get screening. So you don't have to get a genetic diagnosis to get screened for HHT. If we already know you have it, then you're already going to get the screening, and we can kind of do the let's be safe rather than sorry, and we can totally test the children. We can do screening on them, especially the things that are not as invasive. And at least get a baseline. The nice thing is you don't have to get a brain MRI every year. You can just get it. We do just get it once, and then you get it again in adulthood. But we can always screen even with without a genetic diagnosis, simply because we know they're at 50% risk. In our clinic, we have had, unfortunately, a lot of young patients that have had strokes because of a brain AVM, and a lot of them are children or just very young. And so we talk about all this, and if the parents are on board with getting genetic testing, then we will help coordinate that. But sometimes if people are really, really, really nervous, we've had patients that don't, and that's okay too. Can still take care of you.
And I'll just add one thing to what Zahra said. It's a good point that you kind of mentioned, is that we certainly can do screening without genetic testing. However, if you're worried about getting denied insurance and we do screening on your child and we find a brain AVM, that also will lead to difficulties in getting insurance in the future. So I feel like we talk about GINA and this discrimination in policies a lot in genetics, as we try to be very mindful of it. But really, anytime you get any test done, any clinical test done, imaging or otherwise, you are potentially opening yourself up to risk for being discriminated against in life insurance, disability, long-term care insurance, those kinds of things.
Exactly. And that's the thing, is that it's not necessarily that you will be discriminated against. It's just that the protection to not be is not there for that. And so there's a lot of reasons. Like I said, so many reasons. I've had a lot of patients for cancer that aren't getting discriminated because of their cancer or their genetic mutation, but because of something else. So Courtney, you said there are some questions in the chat. Feel free to read some of those out since we've gone through these.
Yes. So I did get one in my email prior to the webinar starting, but I think this is a very interesting question. Amy has a question. If I'm already in something like 23andMe, a direct-to-consumer test, can they get my genetic data from there?
Do you want to do it? You want me
I
to?
can do it. I can start. You can add in. So the short answer is no. They can't, and it's a very different kind of testing that's done. So without getting into details or technical things, they don't. Most of these companies don't do sequencing of genes when they do Ancestry.com or 23andMe. There are some companies now that are offering things like genome sequencing direct to consumer. And in those cases, yes, in theory, the sequencing was done. And yes, in theory, we could get some information from them, but those are the minority of companies right now. Most of them are not doing full gene sequencing. So that's the first major caveat, is that most of these companies don't even have the sequencing data on these genes. The second caveat is that the reason that there are certain labs that we use over and over again, these labs that we call CLIA certified, which is like a large organization that certifies genetic testing labs in the US, is because these labs have to prove to regulatory bodies that they can detect genetic variants and that they're not just not making up the results, but they're not being lax in what they're doing. And so these labs are tested. They will get routinely, yearly, they will get samples from the oversight body, and they will have to prove that they can detect the samples, the genetic changes in them. So while genetic testing, it seems absolute, it seems like, yes, you get a yes or a no answer. There are many instances where you don't get a yes or no, you get an in-between answer, and the interpretation of that is dependent on the lab. But also there are, if you don't do the testing correctly from the beginning, you can miss things if it's not done, if the testing isn't done up to clinical standards. So I would absolutely caution people against using any information they might find from direct-to-consumer testing. We always have to confirm it clinically. And I'll give a short story, not at the expense of taking up more time, is that even like 23andMe will report out BRCA1 and 2 status. BRCA1 and 2, BRCA1 and 2 are these genes that increase, significantly increase risk for breast and ovarian cancer and pancreatic cancer. But they only test for the common variants that are present in certain populations. And we have had patients come to us in our clinic who have a very strong family history of breast cancer and will tell us, well, 23andMe said I don't have a variant. And we say, well, but you're not from that, the variants that they test for are not common in your ancestry group. And when we test them, we find that they do have a BRCA1 variant that was missed by 23andMe because they weren't looking for it. So there are many, many reasons why we as geneticists and genetic counselors like wring our hands and bite our nails when we hear people saying that they did direct to consumer testing. I did it. I did 23andMe. I think it's interesting and fun to do, but it's not clinical testing.
Yes, agree. I also did it. It was fun, but not for
like, is my earwax
genetic
sticky?
counselor.
Yeah, is my earwax sticky? Does cilantro taste like soap? Can I roll my tongue? Those are all great. You can do that. And what is your ancestry? That's all great. But as far as a genetic test, you need a clinical genetic test.
Yeah. Okay. So next question is from Fatima. My son was tested due to an AVF detection and confirmed with RASA1. Is there any data regarding how frequent we should be performing MRIs or any similar scanning?
So I can, as a clinician, I can take that one, I guess.
Yeah, I don't know the answer.
The answer is there are not strong guidelines for RASA1. These are newer diagnoses. Like HHT due to ACVRL1 and ENG have been around, like we showed, for 30 years. Like we've known about these conditions, and they're common enough that there are enough people that we can have good big data sets to draw from. And we can say, well, that seems reasonable to get a brain MRI once in childhood, once in adulthood, just like Zahra was saying, and to screen for pulmonary AVMs every 3 to 5 years. The things that we say is based on data. But with these newer discoveries, we just need to wait more time to have more patients to know exactly where the data shows is the time to do the right things. Now, there is harm to screening more than we need to. Right? Every time you get a test, first of all, MRIs, nothing is completely benign. If you're getting an MRI with contrast, there is, you want to avoid getting contrast as often as possible. If you don't need it, you should avoid it. But also we can incidentally discover things that are just really, truly incidental, and then they lead to more workup and more costs and sometimes unnecessary biopsies, things like that. So, it's not always that like screening more, getting more MRIs is better. So it's always going to be a discussion between you and your provider. If not all providers are familiar with these conditions, and so they might not have an opinion, in which case I think it would be definitely reasonable to seek a second opinion at a larger center that sees more RASA1 patients. Even here at Penn, at Children's Hospital of Philadelphia, right across the street, like, we have a lot of geneticists here. But I will say that, like, if we make a RASA1 diagnosis, which we sometimes do, I often will refer those patients to our colleagues at Children's Hospital, where they have a very strong lymphatic malformation, capillary malformation program. So it's not that I can't take care of them, but we have people who are even more expert at this very rare condition there. So I would say the best thing to do is just look for the people who see the most of these patients. Geneticists are the first stop, I would say, probably. But then, there are certainly some centers that specialize even further, and they can give you more concrete guidelines. They'll probably be tailored to you and to your child, because we just don't have great data to go off of. And it's all going to be a discussion about what risk, not what risk, but what is acceptable to you as a family and what is recommended by us. And we'll meet somewhere in the middle.
Yes, definitely consult your HHT doctor. And if you can't get in contact with one, you are more than welcome to email hhtinfo@carehht.org, and we will get you connected with a medical professional to help you with that. And then one other question from Emily: what resources are there for prenatal preparation for patients in HHT? I'd like to become a mother, and I would like to figure out all I can before.
That's a great question. It's also a loaded question. So when if someone has a diagnosis of HHT and they want to discuss family planning, we refer them to a prenatal genetic counselor. So that's the first step. Talk to a prenatal genetic counselor. We have so many options of testing prior to becoming pregnant, testing embryos and doing IVF. We also have testing that can be done during the pregnancy, because if we know exactly what's causing HHT, we can look for it. The big thing is that it's not super common, or at least I'm not as familiar with people doing testing embryos for HHT prior to, just because it's a condition that's very manageable. Yes, it can be really hard to manage sometimes, but for the most part, people can live generally healthy lives when they're taken care of, and they can live, just without too much, like managing the nosebleeds and managing the AVMs, things like that. It's pretty doable. But there is the option to do basically what you'd be doing is IVF, which is taking the egg and the sperm, combining them, and then testing the embryos to see, are those embryos affected with HHT or are they not? And then there's the option to implant the ones that are unaffected. Obviously comes with a cost and all those risks as well, but you can talk to a prenatal genetic counselor who will also work with reproductive endocrinology to do that. But sometimes, people want to know during pregnancy if their child is affected. And again, that would be helpful to know at the time of birth if we're going to be doing the MRIs. And so those are options that are available as well.
Right. That was the last.
And let me actually, I'll add one thing from like the mother's perspective. If there's a mother affected with HHT, one thing that is no longer recommended, and we sometimes see is like a misconception, is if a woman is planning her pregnancy and delivery and is thinking about getting an epidural, like a spinal anesthesia, basically, there used to be this recommendation that woman get in complete spine MRIs to look for AVMs in the spine before doing that. That is definitely overkill, and we no longer recommend that. If anything, the downsides of getting a full spine MRI outweigh the tiny, less than 1 in 100,000 risk that a patient actually has a spinal AVM at the location where they're doing the epidural. So that's just one thing that you might see in the literature. We no longer recommend that.
But I'll follow up by saying we have plenty of moms who have children and can have perfectly healthy pregnancies. I mean, that's how people get HHT. They have children, right? That's how we have these families. So it's definitely something that that can be done and can be managed well.
Yes.
Right. Thank you guys both for answering all of those questions. I know that many of the people who could not be on tonight had a lot of questions, so I'm glad that we got some of those in there. Last few things, I'm just going to plug one more resource from Cure HHT really quick. So this is the Rare Genomes Project. This project is sponsored by Cure HHT. They work with us. The Rare Genomes Project works with the Broad Institute at Harvard. And so you should definitely consult your HHT physician in your center if you have not had genetic testing done, or if you are clinically positive for HHT, but have had negative genetic testing. What they do is they have a huge lab and they go in and they try and see if they can't identify what that mutation is. So this is fully remote, it's free. They've had a few very interesting case studies. So if you're interested in learning more about this, you can email me and I will put you in touch with our project leaders at Rare Genomes. And my email is courtney@curehht.org. And if anyone has any additional questions tonight, also please email me and I will pass them along to Zahra and Dr. Drivas, and we will see if we can't get your questions answered. And I just want to thank Zahra and Dr. Drivas for taking the time on their Friday night to be here and present with us tonight on the ever so important topic of genetic testing in HHT. And lastly, I just want to give you a quick word from our sponsors before we say goodbye for the evening. This online education session is brought to you by Nampons, who are sponsoring our Awareness Month. By now, you've hopefully heard of Nampons, one of our proud supporters. It's an FDA-registered over-the-counter treatment designed specifically to treat your nosebleeds, and they've been used by tens of thousands of people, many of whom with HHT have handled their regular nosebleeds. They're small, easy to carry, and have hypoallergenic clotting agents that won't interfere with any medication you may be on. They're non-stick, they won't reopen your nosebleed, and they expand inside your nose and absorb a lot more blood than tissues or cotton, and they're safe to use with children, adults, seniors, and they are used by pediatricians, allergists, ENTs, and hematologists. As a sponsor, they're offering 10% off to anyone with HHT. If you want to visit nampons.com/curehht, they'll give you 10% off of some Nampons. And as a final goodbye, if you would like to receive more resources like this one, we encourage you to sign up and receive our email and fill out our post-webinar survey that will be sent out right after this. And on behalf of everyone at Cure HHT, I want to thank you guys all for attending tonight's webinar and staying connected with us. We hope you really enjoyed tonight's programming.
Thank you all.
Thank you. Thanks everyone. Have a good night.